most commonly used drug in nephrology OPDs, the sodium bicarbonate tablet. In this video, we'll see regarding this particular drug in a short overview. First, what is it? This is the drug which contains both sodium and bicarbonate, both electrolytes in the equivalent composition. Well known by the trade name nodosis. There are many other trade names which are available in the form of subosis, soda bake, and soda bicarb. Like many other trade names are available and so on. The dosage which is commonly available is 500 milligram, 650 milligram, and 1 gram. It is available in the gastric resistant formulation also. Gastric resistant coating formulation. When this soda bicarb having multiple uses, but today we are considering this discussion related to chronic kidney disease patient. So this is a bicarbonate tablet which is given to neutralize the acid load in the CKD patient. To understand or giving a bit detail regarding this, the kidney having three main functions. One is the maintaining the homeostasis, endocrine, and the excretory function. In the homeostasis, maintaining the acid base, the most important regulator in the body is the kidney. The acid load comes from the diet and also through the endogenous generation of the amino acid metabolism. If the kidney functions is not meeting the body requirement, the acid load might start accumulating in the body. The normal pH in the body is 7.35 to 7.45 and the normal bicarbonate level is 24 milliequivalent plus or minus 2 normal bicarbonate. So when this acid base regulation is not occurring properly, this might lead to the accumulation of acid in the body. So the patient will develop metabolic acidosis. So what are all the problems this metabolic acidosis can bring? There are multiple detrimental effects of this metabolic acidosis. To name a few, it causes accelerated bone degeneration, accelerated muscle wasting. It maintains a generalized inflammatory state in the body and also causes endocrine dysfunction like increased parathyroid hormone, which causes further this bone problem. Anemia, one of the silent contributor, and many other systemic individual organ specific problems also there. Limiting to the discussion, I'm stopping over there. And another one is the metabolic acidosis itself causes progression of the kidney disease. Already the patient is in a CKD stage 3, the stage might jump from 3 to 4, 4 to 5. The accelerated progression of the kidney disease can happen. So these are all the impacts to name the important impacts in the body because of the metabolic acidosis. So to handle this, we need bicarbonate replacement. So how is the bicarbonate available? Bicarbonate replacement. Ideally, in ICU situation, we need a rapid correction where we use the IV drugs, which is usually seen in a very sick patient. Whereas in a stable chronic kidney disease patient who are on the outpatient basis treatment, the bicarbonate we can give orally. There are many other oral formulations are available. Most common being the soda bicarbonate, sodium bicarbonate tablets. It is available in the normal tablet form and also in the resistant gastric coating form also. So this is the availability with respect to the formulation. What is the dosage availability? It is available under 500 milligram, which is being most commonly used 600, 650 milligram to 1 gram tablets. This is the three formulation which is available. So this is how the drug looks like. It is mentioned as DSS double strength, nodosis double strength. The brand name is nodosis. The drug is sodium bicarbonate. This 1 gram drug. So this is the size of the drug. Ideally, it comes in this much size only, and 500 milligram tablets are also available. Regarding the cost, it is not costly. Price is cheap because few patients use baking soda also in many allied science treatment. They consider baking soda in the treatment of metabolic acidosis. So this drug is that bicarbonate formulation. Coming to the dose, the most important part, not the drug dose, bicarbonate dose. Let us take a 500 milligram tablet. How much bicarb is there in terms of milliequivalent? How much sodium is there in terms of milliequivalent? On an average, approximately we can say 6 milliequivalent of bicarbonate and 6 milliequivalent of sodium in a 500 milligram tablet. Because in IV formulation, it itself being given very clearly what is the amount of bicarbonate in that. Because it is given in milliequivalent. Because we are dealing the ABG and telling the value of bicarbonate in the milliequivalent, you should use milliequivalent in the dosage also. So 500 milligram of tablet soda bicarb contains bicarbonate 6 milliequivalent. So if we give 500 milligram TDS morning, afternoon, and night, the patient will be receiving 6 milliequivalent in the morning, 6 in the evening, 6 in the afternoon. A total of 18 milliequivalent per day the patient might have received. So what is the starting dose in a CKD patient? And what is the ideal bicarbonate level in the CKD patient? There are various guidelines to say as similar to normal will be better. But if we take the cutoff value, even for a multiple choice question, it is the 21 milliequivalent. If the patient bicarbonate level is reaching to 21 or below that, that is the time where you have to start adding oral bicarbonate replacement, because the patient will be developing acidotic milieu in the body. So patient arterial bicarbonate level. This bicarbonate level in the outpatient, unless the ABG is done, very difficult to do. Or there are certain labs which check bicarbonate level directly. So this is regarding the blood level target in a CKD patient when to start the bicarbonate. When to start this oral sodium bicarbonate tablets. And is it fixed for a particular patient? The 18 milliequivalent per day. The starting dose may vary from 0.5 to 1 milliequivalent per kg per day. Since we are adding only the supplement of bicarbonate, along with the bicarbonate, the diet acid load reduction will lead to the towards normalization of the patient bicarbonate level. So after adding 500 milligram TDS, if the patient acidosis level is not coming under control, which is checked through various other parameters, through the patient tolerability, patient response, patient overall endocrine profile, we have to titrate the dose. Many a patient who's having a severe acidosis might require 1 gram TDS also, or further dose adjustment as per the acidosis level. So these are the dose titration where a clinician have to decide and proceed. What to consider whenever we are giving soda bicarbonate tablet? Many resident might be saying as soon as they saw CKD, they will start adding this drug. But there is one disadvantage of this drug is that not only bicarbonate, the sodium also enters the body. For example, a patient is in congestive cardiac failure. If you give excessive sodium, that might lead to the further fluid retention, because we might be telling them low salt diet, but we might be giving soda bicarb tablets. So this sodium might increase the sodium load, thereby water retention in a CCF patient, and it causes most common clinical problem that we encounter is the bloating. So bloating, why? Okay, while telling this as a adverse event, very easy to mention and go. But if we take a particular patient who is typically a diabetic, hypertension, and CKD, they will might be on multiple drugs. The pill burden might be very high. So adding this nodosis to the pill burden might lead to severe bloating. The patient might not take or miss other important drugs. So that is why the overall profile, the progression, impact of the acidosis, everything have to be taken into consideration. while giving this drug. Any other side effect of this drug is nausea, vomiting, and other usual side effect with any other drug you can add here. With respect to CKD, the most important is sodium retention and the bloating. And when to give this drug? Preferably 2 hours before the food. Why there is severe bloating? Because in the gastric acid milieu, this bicarbonate combines and form H2O plus CO2. The gas which released, the patient might feel uncomfortable. Many a times we have seen patient presenting with severe abdominal pain, and then if we keep on adding PPI, it might not respond also. So that is the time where you have to stop the drug. So apart from this, any other use of this oral soda bicarb tablet, we have considered the discussion related to the CKD metabolic acidosis. So pertaining to this, more info is there. Another common question the juniors ask is, sir, at what stage it have to be added in CKD? It is stage 3, 4. If we take the EGFR cutoff 30 to 45, is the time where the patient's ability to handle the metabolic acidosis goes down. So that is the time you have to consider bicarbonate replacement. It's not hard and fast. As soon as patient hits this, you start the drug. No, it is not like that. You have to see what is the level of progression, why the patient is a case of CKD, what is the etiology, what other factors causing the progression. Everything have to be taken into consideration, and also the pill burden. Pill burden also to be taken into consideration. Overall symptoms, then you consider adding. So preferably what stage? This is the stage where patient acid base balance can go down. Yes, this is the stage where you have to consider the drug also. So this regarding the CKD metabolic acidosis. Other few indications are renal tubular acidosis, where the patient is stable and bicarbonate replacement is required in a long-term manner, and also in the urine alkalinization, which might be required, and any other use. Theoretically, if we say, they say acid disease, acid peptic disease being given theoretically, but practically no. Not even a nephro or physician, no one is using the as drug to neutralize the acid load, because PPI and other drugs are there for that, which are better than this one. And any chronic metabolic acidosis due to any reason you can consider, but this is the most common one. And rest of the severe metabolic acidosis, we always go with the IV form. When the kidneys are functioning well, the acid-base balance being controlled by the kidney, so no need for the long-term replacement. Another question with respect to AKI. AKMA, should we give or not? Since it is acute kidney injury, there is a chances of replacement. There is a chances of recovery. The patient will recover fast in case if it is so. So that is why the chronic metabolic acidosis is very rare in this situation. If the patient AKI is in acidosis, you can correct it with IV formulation. Oral formulation might not required. And if the AKI part is recovered, the patient might not require replacement because kidneys are already functioning well. It will replace the acid-based regulatory function. And another question, in a dialysis patient, should we give or not? If the patient dialysis clearance is being achieved adequately in a dialysis patient, we might not replace it if the bicarbonate levels are normal, because it adds to the pill burden and the abdominal discomfort of the patient. So this is all regarding the short discussion on this drug, sodium bicarbonate. And one thing I forgot is the disclaimer, which is supposed to be on the first slide this video. This is only for the medical students. Individual patient requires personalized treatment. No treatment can be uh, started or given based on a YouTube video. So this is for the medical students, and the patient or any another person saying there are many other things which have to be considered, and this is general information and it's not a recommendation for a treatment. Bye bye. We will see you in another video.